Assalamu alaikum. Good afternoon, ladies and gentlemen. My name is Samar AlSwailem. I'm working in KCASH. It's my pleasure really to present to you the ocular surface reconstruction lecture, which is part of the subspecialty lectures. I have 25 years experience in practicing in ophthalmology, and I have no financial interest or relationship to disclose in this lecture. I would like to have this lecture be in an interactive way, so feel free to stop me if you don't understand anything. Most of the things are written in the slides. Okay, I'll try to point to the photos if needed. Okay, so this is the outline of my presentation. I'll start by talking about the ocular surface health, and then I move to the early management, then approach to treat ocular surface disorders. We'll talk about later the amniotic membrane transplantation thoroughly. Then we will discuss the conjunctival flap, limbal stem cell transplant, keratoprosthesis. So, what's the meaning of the ocular surface? This is a term that you see it written in a lot of articles, and whenever we say the word ocular surface, we're talking about the mucosal lining between the upper and the lower lids. And this mucosal layer, you know, is a big, you know, when you talk it's a really it occupies a big area of the external eye surface. Have also the lacrimal glands that contributes to the tear films. We have Montgomery gland that's essential for the tear film stability, and then the tear film which is composed of three components. Okay, epithelial stem or the progenitor cells. And whenever we have a reduction in the number or the function, this will lead to a limbal stem cell deficiencies, and limbal stem cell deficiency, if it reaches the fourth stage, it will cause corneal blindness. Okay, so that's the importance of having a healthy ocular surface. So, and we have another terminology that we use also. We call it the ocular surface disease or ocular surface disorders, which is a group of disorders of diverse pathogenesis in which the disease results in the failure mechanisms that maintain a healthy ocular surface. And this is one of the books that I really advise you to check if you want to know more about it. The list is very long of these ocular surface disease. Can any one of you just tell me what are the most common ocular surface disease that you may face in the clinic or emergency room? Anyone who wants to volunteer? Rawa. The causes of examples of ocular surface disease. Okay, anyone? You can? Yes. Continue, Arwa.
Chemical injury also.
Chemical injuries is one of the most important examples that you face in emergency room. Excellent. Okay. You're still seeing some of the old patients who are having a corneal scarring from trachoma, and they tend to have a banus. And when you avert their lids, you will see arthritis, and this is a Herpes spitz, which represents limbal follicles. Okay, so in acute stage of trachoma, there will be follicles at the limbus, and this is when they scar, they leave these Herpes spitz. Another example which Rawa mentioned is chemical injury, and this is in one of the patients with alkali. Okay, you can see bleaching. Okay, and then with the healing process, with the vascularization, this is an end stage, and this is total ischemia in the acute stage. Another cause which is related to contact lens. You can see here the contact lens, a tight contact lens. What does it do to the stem cells whenever you have a tight lens syndrome? Okay, you can see all the new vascularizations, the destruction of the stem cells, and this is the vortex pattern, okay, associated with it. Okay, so these are the real examples of ocular surface disease. And here it's aniridia. Aniridia is part of the aniridia, by the way. It's not only a missing of the iris. You have a lot of abnormalities. In the cornea surface, we have limbal stem cell deficiencies. And this is another example, Stevens-Johnson syndrome. It's not very common, but we're still seeing it, more common in Southeast Asia. It has a genetic predisposition. Luckily, we are not predisposed as a Saudi to this. And then we have the ocular cicatricial pemphigoids, which is common in Saudi patients. So how do we manage? In order to manage, really, we need to detect first. We need to diagnose first by picking up the signs. Most important one is that you will start to have like a loss of limbal anatomy. You will not be able really to localize the limbus clearly. In normal patients you can localize it, but in stem cell deficiencies it's really difficult. BED, persistent epithelial defect. What's the definition of it? How many days? 2 weeks. Anyone? So the consensus among the cornea specialists is that the persistent epithelial defect, if it lasts between 10 to 14 days. So if it's really extending beyond that, really this is an alarming sign of limbal stem cell deficiencies. How many days would it take for the corneal epithelial to repopulate if you remove the whole epithelium from the surface? Or in another way, if somebody is presenting to you to the emergency room with total epithelial defect, let's say he's 12 years of age, and you're following the patients for the healing, when would you expect that to heal? Give me a number. Healthy. Walid? Usually 5 days. Well, normal has to be 5 days. That's if you remove the whole epithelium, tamam. So you can see if it extends beyond that 10 to 14 days, this is a sign that you have an imbalance, and we mentioned that in the Tuft hypothesis, صح? Okay. And then we have a conjunctivalization, whereby whenever you don't have an ability of the stem cells that are located in the limbus to repopulate the lost epithelial cells, then the conjunctiva will take over. And then the conjunctival epithelial cells will grow on the top of the cornea and try to cover the defects. And that's what we call a conjunctivalization. Or sometimes some of you call it a neovascularization. And in conjunctivalization, it's not only a presence of the blood vessels, but there should be some metablastic or fibroblastic actually cells to say that there is a conjunctivalization. Another way is that clinically, whenever you place a fluorescein and there is a diffuse permeability of the topical fluorescein, like here in this picture, okay, into the anterior stroma, this is also another sign, because this shouldn't happen. If you have an intact epithelium, the fluorescein shouldn't go through it. Okay, but it's when you're talking about a sick epithelium covering the cornea, because it is a conjunctiva, it's not a cornea, it will allow the fluorescein to diffuse through and to stain the stroma. So this is another sign of limbal stem cell deficiency. And what about objective ways? So now we talk about subjective ways, right? So now we need an objective method to diagnose a stem cell deficiency. On the top of it is something we call cytology, and it is the gold standard. It's a gold standard. So you can do it with a filter paper, and then you just put it on the cornea, and then you can send it to the cytologist. They can read it, and then they will tell you this is a conjunctiva, it's not a cornea epithelial cells. Okay, and what's the characteristic of the conjunctival epithelial cells? Anyone? Goblet, because cornea doesn't have it. Excellent. And then these cytologists, they will try to use some certain stains that are peculiar to the conjunctiva, the CK19, CK13, cytokine 7, and mucin 5FA, and then they will try it. So this is a different way of staining them. They're going to use all these chemical stains, and you can see that there is a difference between the cornea, limbus, and conjunctiva. Okay, so the cornea has a unique biomarkers that you can use, stains that you can detect, and then if you have in the conjunctiva also, you have a different way. So you will not have the K12, you will have K13, K7, and so on. Anyway, if you don't have a cytology, you can go ahead and do biopsy, but it's not the gold standard. And then the most popular one, if you have an access to it, is the confocal microscopy. It will confirm to you that this is a conjunctival epithelial and not corneal epithelial. Another way that is not specific is by the use of stains. You see us using a lot of stains in the clinic, and it's a very popular way, and it's the cheapest one, and then we can detect dry eye disease. So there are two types of the stains. The ones that are really very specific are the Lisbon green or the rose bengal, and the ones that are not specific are the fluorescent. And ocular surface, specialists like to use the Lisbon or rose bengal because they detect immediately any dry spots, okay, and the conch and the cornea. If you're going to use the stains, you need to look into early signs. And the early signs is opposite to what you're thinking about. It should be the stain of the conjunctiva rather than the cornea itself, okay? And the early signs is that the interpupillary fissure. So these are the early signs of dry eye disease. Another way of diagnosing dry eye disease is what has been described by the American Academy of Ophthalmology, and the gold standard nowadays by the American specialists is the use of tear osmolarity. Okay, so they're not using anymore these stains. So in order to diagnose, really you need to confirm that there is an increment in their tear osmolarity. If it is more than 302, okay, plus or minus 6, standard deviation, okay, so this indicates that the patient is having dry eye disease. So I need really to be careful about it. It's not stain anymore, it's not Schirmer test anymore, it is the tear osmolarity. Okay, it's a little bit expensive, but it's being covered well in the United States by their insurance. Other way, which our colleagues, the ocular surface specialists, they do it in their research, is that they can check the inflammatory biomarkers, MMB9 and lactoferrin. Another way to also diagnose dry eye disease is that to look into the serum antibody, and we can look into the ANA, rheumatoid factor, anti-Rho, and anti-LA. What are anti-Rho and anti-LA? For the Sjogren's. Beautiful. Okay. One of the common tests that we are doing for our dry eye disease patients, and also in the initial assessment of patients with ocular surface disease, is that we subject the patient to something called keratograph. There are a lot of machines in the market, but this is one of the first one, and it established its presence. There are a lot of other companies, in France and so on, but they do the same job. What's the importance of this? Is that it's similar to Pentacam. You just let the patient sit, and it will measure the tear film, it will measure the stain, it can and take a pictures, and allow you really to follow up your patients and give you the grades, okay, before and after a treatment. And most important is that it will give you the meibomianography, and this is meibomianography. So it will show you if there are healthy or unhealthy, and will give you all the degree of abnormality. So for here, like for instance, this is a 0. There are no tunnels, So and then here, sorry, this is a healthy one, is 0, and then here is no tunnels. Yes, the reflections here is very high. If you go to our clinic and ask for the keratograph, you will be able to see it much more clear. Here it's not. Here is clear because you can see here. This area is dead. There are no meibomian channels, and here there are a couple of, and here more and more, and here in whitish. So this is a healthy one, and this is here absent tunnels, indicating that this patients have a very severe meibomian gland disease. So anyone wants to volunteer for the first check? Yes. طيب تاخذي بس المايك من دكتورة روعة. Can you read, please?
All statements are correct except function of progenitor cells may be reduced in LSCD. Corneal epithelial biopsy is the gold standard test to detect conjunctivalization. Tear osmolarity is the standard to detect the delayed epithelial DED.
Conjunctivalization, صح?
And PED is a sign of LSCD. I think 3 لأنه 2 it's not the gold standard to take.
What's the gold standard? Cytology, صح?
Cytology.
Yes. Perfect. All agree? Like. So, in the first part, we discussed what's the meaning of stem cells. We highlighted the ocular surface disease and how to diagnose ocular surface disease. Now, how can we manage ocular surface disease or ocular surface disorders? It's a stepwise approach. And the most important one is that to suppress the inflammation. This is the number one. And this will be followed by eliminating any toxic medications and controlling glaucoma. Then maintaining the wet surface. Then we need to correct the eyelids, eyelash abnormalities. And then protect the integrity of the ocular surface. And promoting the ocular surface healing. Lastly is restoring the globe integrity and covering unstable ocular surface. So then last thing is that you're gonna do the surgical treatment. So when I brought these slides, I wanted you really to focus on a lot of things. Is that it's a multidisciplinary, right? It's not only the anterior segment. So really we need to work side by side with oculoplastic, with the glaucoma colleagues in order to achieve the target before moving into the last stage, which is the surgical intervention. And the surgical intervention, it depends on the staging. I didn't bring it to you because you're not requested to know the stage, you're not a fellow, but anyway, simply is that we can say if it is unilateral, okay, or it is a mild bilateral, we say stage 1 or 2, you can just observe, just do all the previous lists that I mentioned to you. In some cases, if it is affecting the visual axis, we may elect to do sequential epitheliectomy, okay, and removal of the banus with or without amniotic membrane. And the setting of severe stages of the limbal stem cell, okay, which is stage 2B and 3, we can decide on which type of surgery to do based on the laterality. So if it is unilateral, you will follow the previous steps I mentioned earlier, and then you may do an autolimbal stem cell from the other eye, or you can use other treatment options that we will discuss in the last section of the presentation. If it is bilateral, you have very limited options, meaning you can't take anything from any eye, so then you have to do from the others. It's allo, either from cadaver or from a relative, okay? Or you may do keratoprosthesis, or you can do something we call a comet from the oral mucosa. So how to suppress inflammation? It's very simple. So it's usually the most common one is the steroids, topical steroids. So you need to hit hardly with the steroids in initial phase, and then you need to replace it with something like a cyclosporin or tacrolimus, okay? And in certain situations, you need to augment that with a fresh amniotic membrane or cryopreserved amniotic membrane, because either one of them, they will have the ability to suppress the inflammation. In certain cases, we need really to give an oral or systemic, okay, and a pulse therapy, but it's contraindicated in elderly patients or patients who are immunocompromised already. So you can use acute pulse of steroids and then shift that to tacrolimus or cyclosporin in order to suppress the eye inflammation. So the toxic medications really is very important to be eliminated from the surface, because it contributes to the damage of the healthy epithelium, and also it kills the stem cells, the progenitor cells. So it's advised to use preservative-free medications in these compromised surfaces. You may elect to use a lipid or osmoprotectants, and in certain conditions, what we do is that we do something called washout period. When the patients come to our clinic with a bag of medications, we stop all the medications for a couple of days, we relieve the ocular surface, and then we start again. And as a rule of thumb, if the patient is using more than 6 different bottles, it's better to use a preservative-free and try to avoid the bag. You know what's bag? Can you raise your voice? هتقول yes. So really we need to get rid of from this toxic preservative. But the good thing is that most of the new bottles nowadays, most of the pharma company are trying to avoid using it because of the side effects associated with it. And then we encourage the patient to stop using all the herbs, and sometimes we ask them to eliminate also any cosmetics agents while the eye is still inflamed. Then another way to maintain the wet surface is not, these topical lubricants will not be sufficient. You really, in certain patients, really we need to use more stronger topical wet surface medications like BRPs, so we can use them in a different percentages, 50 up to 100, and we have the Indort, which is even higher in concentration than BRP. The other thing, in order to maintain the wet surface, it's always advised to check the meibomian gland, because the lipid layer prevent the evaporations, and it plays a very important role in stabilizing the surface. So whenever you have MGD, you can go ahead and treat it, but nowadays a lot of the ophthalmologists are using the IPL, intensive pulse slide, or the LipiFlow, and in addition to the medications. What are the medications for treatment of MGD? Standard. Can't hear you. Doxycycline, excellent. Systemic. What else? If you don't have it. Anyone? It's azithromycin. So if you check the meta-analysis, you will see that that you can use the doxycycline or systemic, or minocycline in the past, but it's a doxycycline and then azathioprine. However, you need to repeat that one frequently, and you have to be careful with the side effects. What are the side effects of the doxycycline? GI upset. What else? You can't use it in a patient below age of 13, for the discoloration, okay, and the sun exposure, burn, and then the azithromycin side effects. Guys, anyone? You know it, and I know. I'm sure that you know it. It's associated with cardiac arrest, a lot of cardiac. It was linked to a lot of strokes and cardiac in high-risk patients. So try to avoid it in these patients. معناه we can use also punctal occlusions, either a temporal one or a permanent one. Okay, and in certain conditions where there is an absence of the lacrimal glands, I've seen a couple of cases in the past. You can do a salivary gland transplantation from the buccal mucosa. You can transplant these cells to the eye, and you can do that also in Stevens-Johnson syndrome and MMB. Okay, what's the difference between Stevens-Johnson syndrome and the other one, Graft-Host's disease? Anyone? Walid, Rawa. Okay, excellent. That's a good start. But what's the most important one? Meibomian gland. Meibomian gland is the involvement, and the salivary gland. Okay, these are the most important things, especially the salivary gland involvement. فهذه differentiation between them. طيب, in the United States, they're using nowadays something called Suvis. It's an FDA-approved topical steroids. It's a very light steroids. Unfortunately, we don't have it here in the United States, and it's been approved for almost 4 years. Until now, we didn't have an access to it. But it's a very mild steroids that can be used to the ocular surface For us, we use FML as the mildest form in Saudi Arabia. And then you need to maintain the patients on topical cyclosporin, like with the different concentrations. We don't have an access until now to levetiracetam, okay, the 5%, which is very popular in the United States. Where they combine both the topical cyclosporin together with levetiracetam, both of them, to maintain a healthy surface. They have an anti-inflammatory, effects. You can, in certain conditions where the patients are having neurotrophic keratopathy stage 1 and 2, you can use another medication. It's approved by the FDA. It's called German. Okay, Oxervate. You've heard about it. It's a very expensive one. It costs up to 20,000 real, just one course of it, but it's only effective in stage 1 and 2. You can use an acetylcysteine in patients where they have a filamentary keratitis, a vitamin A ointment in the settings of keratinization. Then what about the correcting the eyelids and eyelash abnormalities? You can do it as an anterior segment surgeons, or refer it to the oculoplastic if they have a massive symplepharon, formation, and they can release it. They can use grafts or amniotic membrane with a mitomycin, okay, and they can put also a ring to prevent it from recurrence. The other thing is that the lag of thalamus. It's really something that we don't like to see, because we need to maintain the healthy epithelial cells covered well. So in the lag of thalamus, we need to do a lot of steps to improve it. Of course, we refer to the oculoplastic, but what initially you need to do while you are waiting is that you can encourage the patient to tap the upper lid, tamam? Or you can do a tarsorrhaphy until you refer the patient to the oculoplastic, a temporal tarsorrhaphy. The oculoplastic, they sometimes inject the patient with botulinum to cause the drop of the upper lid, tamam? And in some situations, you can do cyanoacrylate, just trying to seal the eye, especially if it's not seeing eye. You don't want it to perforate. And at the end, some of them, they're doing gold implants. Correction of the entropion and ectropion is very important. Anything that will destroy your epithelial or to rub against the epithelial surface needs to be removed. And also the misdirected lashes. Sometimes we insert actually a contact lens, although we discourage patients from wearing a contact lens 24 hours, but unfortunately that's the only way to protect the corneal epithelial cells and the stem cells at the limbus from the injury, direct injury from the lids. So you can put a contact lens, the high oxygen permeable one, mainly the silicone hydrogel. Okay, and it's available. You can check with the optometry, or you can just send the patients for a fitting with a scleral contact lens. In the United States, they're using a Bros, which was started in Boston school. It's a very expensive one. They fit it. It's a customized, but more or less similar to the scleral contact lens that we are fitting our keratoconus patients with. So they are the same, except it has more oxygen permeability, and there will be larger bucket for the accumulation of the aqueous as a source of nutrients. But whenever you put the patient on a contact lens, please make sure that the patient is taking a topical antibiotic. I think it's your really job while checking the patients in the emergency room, if he is using a contact lens, that he is having a coverage with it. It's a very important. Please, don't just discharge patients without checking the antibiotic use. Sometimes we prescribe a moist chamber. You've seen it before, or we do on an alpha-amniotic membrane just to maintain the surface. And I've written with my colleagues chapters in Jacobics, and there are another also publications about the graft failure. I discussed thoroughly all the ocular surface. You can review them, but and nowadays we're using a lot of new techniques. Here in Kikash, we have a limited access to it, but those who are practicing outside can use it. It's a cord blood, so umbilical cord blood, because it has a very concentrated, concentrated materials containing neurotrophic factors and very important factors. Amniotic membrane extract, they're available commercially. I've tried them also on my VIP patients, and there are a lot on the markets. Regener is one of them, Kera, Lipothelize, and they come in two different, the thin one and the thick one. The thick one needs to be refrigerated all the time, but I think they are really effective. One thing is that which I want you to do is that whenever you are in emergency room and encounter any patients with chemical injury, is that please refer the patient to anterior segment in the first 72 hours, especially if the patient is having an epithelial defect. Okay, you can manage by yourself, but if the patient is having an epithelial defect, then I would advise you to refer the patient to us, because this is the window for us to do the amniotic membrane. A lot of evidence in the literature, and that was proven by prospective studies, prospective comparative, is that the success rate will be much higher if you do the amniotic membrane in the first 72 hours, okay, in acute chemical injuries. And then after that, the importance of doing it will be less. The reason behind, amniotic has an anti-inflammatory properties which will suppress the inflammation. It will maintain the stem cells, so there will be no loss of the stem cells, and it's very important, and keep the eye very quiet. In a setting where the patient is having a perforation, we need to measure it. So if it is less than 2 millimeters, usually can be managed by a general ophthalmologist or a senior, even resident. So by an application of what we call a cyanoacrylate adhesive. It's not the fibrin. The fibrin glue, whoever was asking me, is not effective. It doesn't last, but when we talk the cyanoacrylate, yeah. And there are 3 different techniques. I can share the slides with you later, how to apply them. And it's effective if the perforation is in 2 millimeters or less. And if it's more than that one, then it's the likelihood of having it, it's not gonna work. It's not gonna stabilize. It will not close the hole. If it is a little bit larger, sometimes we use the umbilical cord patch, okay? Or we can do the multiple layer amniotic membrane. And under research, they're using something called collagen vitrigel, and it's a type 1 collagen if you don't have an access to amniotic membrane. The other way of stabilizing or restoring the globe integrity is that you need to cover the surface. So let's say you've tried a lot of amniotic membrane and it didn't work, and the surface is sick. So you need to have other alternatives. So, and if you want to cover an exposed corneal surface, a large ulcer, you can use a conj flap, or you can do the amniotic membrane, which we mentioned, or the umbilical cord patch. If you have a defect in the conjunctiva that's not responding to all the previous measures, you can use a conj autograft from the other eye, or you can even use a conj flap, especially in pterygium surgeries or chemical injuries, or you can transplant an oral mucosa or nasal mucosa. Nasal mucosa has a stem cell in it, and it's a very thin compared to the oral mucosa. But the nasal mucosa, really you need to help of oculoplastic to harvest it, as well as the oral mucosa. The scleral defects can be covered by a scleral allograft from the donor, from the eye bank, or by a corneal tissue, whether a full thickness or a desec lenticule, or we can use even the pericardial patches. So this is an example of patients who sat exposed at pterygium surgery long time ago, and they use probably the mitomycin because it was popular in the past, and a lot of people were using it like for 2 or 3 minutes with a higher concentration, and the side effect is scleromalacia. So we covered that patient with a scleral patch, and we could cover it with the desec lenticule or with the corneal patch and so on, because you don't want to have a full thickness hole. The area is really critical because it's at the limbus, and you will soon start to have a filtering bleb if you don't cover it urgently. And here the characteristic of the biomaterials that can be used to cover the ocular surface in a term of the stability, the thickness, okay? So as I said, that some of them are thick, some of them are thin, and the color, Okay, the only colorless one is the amniotic membrane, while the autologous conjugaft, oral mucosa, and nasal are pinkish. The transparent one, the most transparent one are the amniotic membrane and the autologous conjugaft without a tenon, by the way, when we talk about the autologous conjugaft with no tenon. And the goblet cells is available in two of them only, in the nasal mucosa and autologous. The accessibility, the most difficult one is the nasal mucosa, as I said earlier. And who has the epithelial stem cells? It's the oral mucosa and the nasal mucosa, while the autologous or the amniotic, they don't have any epithelial stem cell within it. So they cannot, give you an epithelial stem cells if you transplant them to the cornea. طيب, anyone wants to volunteer? I think because of the time. Anyone? Can you pick up the mic? يلا دكتور وليد. Okay, 2 is the correct one. What about the cyanoacrylate? Beautiful. So that's why I brought it, because I've seen a couple of cases referred to KCASH whereby they were trying to cover the scleral defects or even the conj with the, it's really ineffective. It doesn't work at all, okay? So that's why I brought that one in particular. طيب, amniotic membrane transplantation, you can check the review article that I published. I described in details the features, indications, how to do the surgery, okay, and the properties. I'm sure that many of you are aware of the properties of the amniotic membrane. It's not only suppressing the inflammation, it also the cause pain reduction. It suppresses also the it has antimicrobial activities in it, but in certain patients, it can be also a reservoir of an infection. So that's why, again, whenever we do this, we're going to apply a contact lens. We have to cover the patient with antibiotics. So be careful with these patients. So how do we do amniotic membrane? At the access of the amniotic membrane, we have a wide access. One of them is the use of the Bruchera. Bruchera is a form of amniotic membrane that is a cryopreserve, okay, that is attached to a contact lens with a ring. You put it, and this is one of my patients, and then we usually put a lateral tersography, and we leave it for like up to 30 days, and it will heal. It's a very nice one. However, the access to it is not here in Saudi Arabia is easy because of the expense. They're still charging us higher than the North Americans and European countries. And there are two types of them, the thin and the thick one. The other one is that we can use the dried amniotic membrane, and this is one of the amniodisc. We had a couple of KCASH. Again, the cost is one of the things. And here we don't have the full properties. It works only as a bandage contact lens. So whenever we put them, we usually even put on the top of them a contact lens, we hydrate them, and then we put them on the surface. What we are encouraging everyone to use is the cryopreserve. Cryopreserve amniotic membrane, they will maintain all the important, material in it. So, and here I have a video to just to show you that this is an amniotic membrane. We have epithelial surface and we have the stromal surface, and this is how we put the amniotic membrane, and then we need to differentiate between the epithelial and the stroma. The sticky is the stroma down. So sticky stroma, and the epithelial shouldn't be sticky. So that's the way. Why we are encouraging you to differentiate, because the stromal side is the one that contain all the important, you know, materials, and that's when we want to use them as a basal epithelial coverage. Tamam? If you want to use it as a bandage contact lens, then you put the stroma on the top. But opposite if you want to have, as I told you, the bandage basal epithelial healing. Here an example how you apply them. It's all described in the article, and this is an example of some of our patients. You can tell the diagnosis. What is it? Huh? Who attended the CTR last time? Aywa, yes. So this is following the excision. So I can see following the excision. So that was a very massive one covering the cornea, and this is following the excision just, you know, by almost like, you know, 1 month we took that picture. You can see how the difference between before and after the shaving of it, okay? And we use I've used the amniotic membrane and I excise all the lipodermoid up to the muscles layer, and with the follow-up now 2 years, I didn't bring the picture, it's almost fainting. So you can use it as an adjunctive way to cover the defects. This is another patient with golden hair, okay? And this is a fresh picture, and this is in a patient where we've done a large tectonic graft, and then we covered with the amniotic membrane. I want to skip some of these videos, and this is before and after for the time. Because of the time, we cannot show you everything. We started late because most of you came late. So this is how we excise the limbal dermoid. And then we can use it for Moran's ulcer because it has a lot of inflammation. We can use it in patients with scleritis. This is an example following a hemicorneal transplant with the amniotic membrane. And the complications, a lot of complications can happen if it's not done in a proper way, like a granuloma formation, a dehiscence, microbial keratitis, hematoma formation, if you don't massage it at the end. And you can fix the amniotic membrane by fibrin or by sutures. Check. Anyone wants to volunteer? Yalla, Walid.
All statements regarding the amniotic membrane are true, except infection never develops after its transplantation, since it has antimicrobial properties. It can be used to seal small corneal perforation. Freeze-dried form can be used as a bandage contact lens. For it helps in suppressing inflammation and acute chemical injuries. So one is wrong. It can develop infection. The other 2 or 3 or 4 are correct.
One. Okay, good. طيب. Conjunctival flap is one of the surgical technique that we use. We have 2 types of conjunctival flap to cover the ocular surface. Either we use the total one, which is called Gunderson, or we can use the partial one. And in general, we don't use the conj flap in the settings of active microbial keratitis or corneal perforations. Okay, so you need to seal that before you put them. And this is the most important reference that we are using so far. How efficient is the conjunctival flaps? The techniques being described very well in that article from Massachusetts. And when do you use it? We use it if there is a little visual potential and chronically rotated corneal surface. You don't have an ability to regenerate epithelial cells from the stem cells, so you can use that one. In the setting of chronic sterile epithelial or neurotrophic, you can use that one. Okay, herpetic keratitis, if it is under control, yes. If it is a neurotrophic stage only, but not the necrotizing stromal keratitis. If you have also unstable wounds in the settings of painful bullous keratopathy or thicical eyes, so you can elect to do that one. And the techniques is well described in that article, and this is an example of the patient, one of our patients, where I put the Gunderson. This is the picture of the patients. He had a neurotrophic, by the way, keratopathy. Patients will complain from the cosmetic appearance because it will give a grayish hue of the eye, but that's one of the only side effects, but otherwise it's a very stable. We usually like to cover eyes where the potential is little with the conjunctive flap. In countries where they don't have an access to these amniotic membranes or distal lenticules or oral mucosa or nasal, whatever, they can do a fast things is that they can create something we call a partial conjunctive flap. Okay, I think it's better to stop at this stage. And this is the last slide just to show you an example of some of the conch flaps that I created, and the bipedical ones to some of our patients. These are the complications associated with it: flap retractions, cysts, ptosis, so on. And we stop at this. And I don't have a check questions. Let me see. Yeah, here. Anyone wants to volunteer in the last slide? Walid.
Which sentence is true? One, total conjunctival flap is effective in autoimmune keratitis. Total conjunctival flap is effective in treating painful bullous keratopathy. Conjunctival limbal autograft is used for bilateral limbal stem cell deficiency. Cultured oral mucosal epithelial transplantation is the first choice for unilateral limbal stem cell deficiency. So 2 is correct, and the remainder are wrong. 2 is correct. Total conjunctival flap is effective in treating painful bullous keratopathy.
Yes, the other one, yeah. So the claw is not claw is
in unilateral.
Yes. Okay. Thank you. يعطيكم العافية.